الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Cold Stress Clinic by Professor Mahmoud Hani Sulaiman. Exposure settings. Only excessive uncompensated heat losses contribute to cold stress. The most prevalent mechanism is by excess connective transfer of heat from skin into air or water. Systemic cold stress occurs when heat loss exceeds heat production, e.g., outdoor activities in cold climates, refrigeration work, as in food processing, and body immersion, as in diving. Local exposure to cold, usually involving extremities, is far more common. This occurs in outdoor workers who not wearing gloves during their work, as in maritime industries and military activities, because local effects is delayed with prolonged exposure. It is need not to be freezing or temperature to be hazardous. Prolonged exposure at temperatures as high as 10 degrees centigrade may induce acute and chronic effect. Prolonged exposure at temperatures as high as 10 degrees centigrade may induce acute and chronic effects. Physiology of cold stress. Responses to cold either systemic or local. Systemic, increase sympathetic and adrenergic discharge plus increase in skin vasoconstriction and shunting of blood centrally. This leads to decreased heat loss, protects internal organs from cooling. In those with disease as increased blood pressure, this will lead to more increase in blood pressure. Adrenergic stimulation will lead to increased platelet aggregation. Cold exposure will lead to increased muscle activity to the extent that shivering. Decreased cold temperature causes ice crystals to develop in extracellular compartments, producing intracellular dehydration, which causes a hyperosmotic state leading to cell death. Upon rewarming, vasodilation and leakage from capillaries cause tissue edema. Alternation of these two processes can lead to ischemic infarction. Frostnip is cooling of tissue without cellular destruction and is the mildest form of peripheral cold injury. Simple rewarming via conduction from another warm body part is typically sufficient to reverse frostnip. Local decrease in temperature will lead to peripheral vasoresistance increase, will lead to increase of peripheral vascular resistance. This occurs spasmodically with cyclic decrease in skin temperature increase. Accompanying this response, there is endothelial leakage and stasis of blood flow, which leads to local tissue injury. With severe or prolonged temperature decreases, vascular necrosis and thrombosis occur. These are the stages of cold effects on body. From above, from 32 to 36 is optimal hand and finger function. Still the function present. From 32 to 27 effects on finger dexterity, precision, and speed. From 27 to 20 impaired performance in work with small details and reduced endurance. From 20 to 15 degrees centigrade, impaired performance of gross hand and finger work with occasional pain sensation. From 15 to 10 degrees centigrade, reduced gross muscle strength and coordination pain sensation. From 8 degrees to 6 degrees centigrade, blocking of sensory and thermal receptors of superficial skin. Less than 10 degrees centigrade, numbness, manual performance, reduced to simple gripping, pushing, etc. Spontaneous, rhythmic, rewarming, Lewis reaction. Less than 0 degrees centigrade, freezing of tissues. So when you are taking history, if you ask it about these symptoms, you may describe the temperature at which the worker was exposed to. Classification of disorders resulting from cold stress, either systemic effects of cold, hypothermia, essential hypertension, thromboembolic disease, menstrual disorders, and local effects of cold, chilblains, immersion foot, frostbite, and cold precipitated disorders, Raynaud's phenomena, and cold urticaria. Raynaud's phenomena is described under vibration. Frostbite refers to cold-induced cell death with localized inflammation plus tissue ischemia, as is shown in the photo. In addition to direct damage to cells and extracellular fluid, indirect effect of released prostaglandins, thromboxane, bradykinin, and histamine from tissue ischemia is platelet aggregation and vasoconstriction. Frostbite classified as superficial or deep. Patients report that skin initially feels painful but then becomes numbness. Tissue appear white, mottled, violaceous, pale yellow, or waxy, depending on degree and depth of freezing. If medical treatment is not sought immediately, bully, Eschers, or tissue necrosis may develop, shown in the photo. Treatment of frostbite is aimed at rapid rewarming. The preferred initial modality is rewarming in a water bath at a temperature of 40 to 42 degrees centigrade. A strict aseptic technique must be maintained to prevent infection. Rewarming continued till tissues has a flushed appearance within 30 minutes, an indication that circulation was re-established. Narcotic medication required to control pain induced by rewarming, as ibuprofen and topical aloe, help to limit inflammation. Tetanus vaccination is given because wounds are considered tetanus prone. There is limited positive evidence regarding use of thrombolytic therapy. Rubbing of frostbitten areas should be avoided, as this may cause further tissue damage. Dry heat should be avoided because the anesthetic tissue may accidentally burn. Surgical amputation and debridement are delayed for several weeks due to the difficulty in determining tissue viability. Chilblains or pernio equal chronic recurrent vasculitis manifested by red to violaceous raised lesions in unprotected extremities. This is shown in the photo. It is caused by exposure to non-freezing temperatures and damp conditions. Blisters, erosions, and ulcers may develop. Treatment involves local heat, gentle massage, and lubricants to keep skin supple. Lesions usually resolve in 1 to 3 weeks. calcium channel blockers as nifedipine used to reduce pain and speed healing. The condition commonly affects young to middle-aged women and is associated with Raynaud's phenomenon. Immersion foot or trench foot is a disease of sympathetic nerves and blood vessels in feet, which develops in individuals whose feet have been wet but not freezing for prolonged periods of time. Wet but not freezing for prolonged periods of time. Patients typically report numbness, tingling pain with itching and cramps. The skin transforms from red to pale and mottled, as shown, and then to gray and blue. The soles of feet are wrinkled and tender to palpation. Treatment involves air drying, gentle rewarming, bed rest, extremity elevation, and early physical therapy. Improvement usually begins within 1 to 2 days, with resolution in 1 to 2 weeks. Snow blindness or ultraviolet keratitis is inflammation of cornea due to excessive ultraviolet radiation. It can be thought as sunburn to cornea. Unprotected exposure to sunlight on highly reflective snowfields at high elevation increases dosage of ultraviolet radiation. Patients typically report foreign body sensation, pain, tearing, and blepharospasm 6 to 12 hours after exposure. Lid edema, conjunctival hyperemia, and diffuse superficial punctate irregularities on fluorescein staining, this is shown, may be noted on physical examination. Treatment involves pain control, antibiotic ointments, e.g. erythromycin, and cycloplegics to relieve ciliary spasm. Cold panniculitis is inflammation of subcutaneous adipose tissue after exposure to cold temperatures. It is most commonly seen in children and obese women and typically develops 48 hours after cold exposure to a poorly protected area. On physical examination, affected area manifests localized indurated nodules, raised, firm, and painful. Cold panniculitis is self-limited and requires only symptomatic relief. Major disorders associated with cold stress. Hypothermia. Hypothermia equals core body temperature less than 35 degrees centigrade. Primary hypothermia, heat conservation mechanism cannot overcome low environmental temperature. Secondary hypothermia, heat conservation disturbed by states interfere with hypothalamic temperature regulation. Shivering, redistribution of blood, and ability to leave environment. These are the hypothalamic temperature regulation. Hypothermia occurs in infants due to they have large body surface area, which will lead to rapid heat loss, and elderly due to their decreased ability to sense low temperature, to decrease heat loss by peripheral vasoconstriction, or to shiver. Drugs, e.g. alcohol, or drugs that act on CNS, e.g. barbiturates, phenothiazines, may decrease body's response to cold and increase susceptibility to cold. Risk of hypothermia increased by hypothyroidism, hypopituitarism, hypoadrenalism, diabetes, sepsis, and head injury. Here is the differential diagnosis of environmental hypothermia. You find a patient with hypothermia. The common causes are hypothyroidism, hypopituitarism, adrenal insufficiency, CNS disorders, and severe burns. If the patient has a history of trauma, then look for hemorrhage, shock, brain injury, intracranial bleeding, and severe burns. If no history of trauma, Check labs, glucose, white blood cells, electrolytes, and TSH. If the patient is with altered mental status, so look for drug overdose like barbiturates, opiates, alcohol, and phenothiazine, or to metabolic or infectious encephalopathy, coma, hypoglycemia, and stroke. If the patient with normal mental status, then look for elevated TSH, hypothyroidism, or low blood pressure, as in case of sepsis, dehydration, adrenal insufficiency, or low sodium, as in with normal potassium, no hyperpigmentation, so hypopituitarism, all low sodium with hyperkalemia and hyperpigmentation, it will be adrenal insufficiency. If there is normal mental status, the last choose is severe malnutrition. Mild hypothermia equal core temperature equal 32 degrees centigrade to 35 degrees centigrade. Patients pale, cool, and have vasoconstricted blood flow to skin. Patients shiver uncontrollably and have degrees of mental status change. Patients have tachycardia, tachypnea, and cold diuresis induced by increased cardiac output and as a result of increased renal perfusion. Moderate hypothermia, core temperature from 28 to 32 degrees centigrade. More severe, impaired mental status, muscle rigidity, absent reflexes, dilated pupils, shivering reflex lost, and blood pressure, heart rate, and respiratory rate decreased. Cardiac arrhythmia is common, and ECG show pathognomonic J-point elevation or Osborne wave. With no ability to generate heat, patient cools to ambient temperature and dies if warming is not accomplished. Severe hypothermia, core temperature less than 28 degrees centigrade, causes patient to appear dead, blood pressure is not recordable, respiratory rate is extremely low, patient is in coma, pupils dilated, fixed, and reflexes are absent. Atrial arrhythmia may be present and ventricular fibrillation easily to be induced even by moving patient slightly. This type of arrhythmia resists pharmacologic or electrical cardioversion without core rewarming. However, magnesium sulfate, quinidine, or beryllium tosylate may be helpful in these cases. This is comparison between mild to early hypothermia with late and severe hypothermia. Please print and use it. Goal of initial treatment of hypothermia is prevention of further heat loss. Basic life support initiated airways and circulation. Cardiopulmonary resuscitation if patients have a non-perfusing cardiac arrhythmia. Severe peripheral vasoconstriction in hypothermic patients will lead to pulse difficult to palpate. Therefore, pulse should be examined for a full 1 minute to help avoid inappropriate chest compression. Oxygen and IV fluids should be warmed before being given to hypothermic patient. Passive rewarming as moving patient to warm shelter, removing wet clothes and apply dry blanket attempted initially in all patients and may suffice for mildly hypothermic patients. Active external rewarming can be added to passive rewarming and include apply exogenous heat sources as heating blankets, heating lamps, hot packs. More invasive techniques for core rewarming include peritoneal dialysis or hemodialysis. Prevention of disorders caused by cold stress. Climatic control is impossible in outdoors or in refrigeration work where cold is essential. So, modification of work to decrease exposure, education to recognize early symptoms of local injury, and use of PPDs. Medical surveillance plays a minimal role, i.e., it is limited to examination of workers who undertake cold exposure occupations to identify those few who might be at special risk. وفي النهاية أقول الحمد لله و thank you for your good listening.